Surgery MCQ Marathon. This is Dr. Pritesh Singh, PrepLadder Surgery faculty, and we will be discussing clinical, integrated and image based question in this Surgery MCQ Marathon. So let's start. So you can see the question number 1. A 62-year-old man presented to OPD for an annual physical examination, right? After noting a PSA level of 12.23. So here PSA level is raised. See the age, 62 years old. You refer him to an urologist for further workup. Following prostatic biopsy, the result shows presence of adenocarcinoma of prostate. So there is adenocarcinoma of prostate, which is given as Gleason score of 8. Gleason score is measurement of, see, so here the patient is having adenocarcinoma prostate. What is the normal PSA? The normal PSA is less than 4 nanogram per ml. This is less than 4 nanogram per ml. So here patient is having adenocarcinoma prostate, right? You know that there is Gleason grade and there is Gleason score. What is Gleason grade? Whenever you take biopsy, the most commonly observed histological pattern is primary grade, and the second most commonly observed histological pattern is secondary grade. I am repeating, Gleason grade, primary grade, that is most commonly observed histological pattern, secondary grade, that is second most commonly observed histological pattern. So Gleason score, if you see, this Gleason score is sum of primary grade as well as secondary grade. So 1 to 5, 1 to 5, and that is why the Gleason score is 2 to 10. So what is the use of this Gleason grading system? It provides a measurement of potential for prostate cancer to grow and spread, right? So see the question. The Gleason score is measurement of extent of cancer within the prostate gland. No. Extent of cancer within the abdomen? Obviously not. Likelihood that the cancer will grow and spread? This is correct. And the number of cancer cells expressing PSA on their cell surface? So this is wrong. Clear? So what is the correct answer for this question? The correct answer is C. I am repeating. Gleason score is measurement of likelihood that cancer will grow and spread. Okay. So here Shivani was correct, Rashmi, Priya was correct. Okay. So let's discuss a bit about Gleason grading system. So we discussed that there are two grade, primary grade, score varies from 1 to 5, secondary grade, score varies from 1 to 5, but the Gleason score varies from 2 to 10. And see, Gleason score has no relation with stage or extent of the cancer, expression of prostate specific antigen and estimated survival time. So it is going to check the potential for prostate cancer to grow and spread. Okay. So Mohan Singh was also correct, Rajesh Sapre is correct, Dr. Monica is correct, Rukshar Khatun is correct, Vandana Rai, almost everybody was correct for this question. Okay. Now see the second question. 72 years old patient with BPH underwent TURP, that is transurethral resection of prostate gland under spinal anesthesia. This question was asked many times. After 1 hour, patient developed vomiting and altered sensorium. What is the most probable cause? First you people tell me, then I will discuss. First option is hyperkalemia, second is water intoxication, third is rupture of bladder, and fourth is overdoses of spinal anesthetic agent. First tell me what is the correct answer. What is the clue? This patient underwent TURP for BPH and this patient is having vomiting and altered sensorium. Yes. Monica, Yogesh, Lakshmi, Madhuri, Ram Vivek, Mohan Singh, Nimi, Siddhi, Kavi, Saptarshi, Trilok, Sujit, Anuj Tiwari, everybody, oh my god, PG aspirant, Bhagyashri, Everybody, Yogesh Verma, everybody is correct except one person. Okay. So, see, this is a typical case of what? Fluid overload, that is known as water intoxication. See, whenever we are performing transurethral resection of prostate, we use 1.5% glycine. The duration of surgery should be for 90 minutes only. Why? If you are going to perform TURP for more than 90 minutes, what happens? The vascular channels are open and there is absorption of this irrigating solution. Because of excessive absorption of irrigating solution, there is fluid overload, that is known as TUR syndrome. This is also known as water intoxication, and this is also known as dilutional hyponatremia. Sodium is decreased because of excessive fluid. So, this is dilutional hyponatremia. So, what is the correct answer here? The correct answer is B, and almost everybody was correct, right? So, how we are going to manage? You tell me. If a patient is having fluid overload or water intoxication, tell me the drug of choice. Tell me. What is the drug of choice? I am waiting for your answer. If there is fluid overload, I want to take out this fluid from the body. What is the drug of choice? Yes, tell me, everybody. I am waiting. Very good. Lakshmikant Lasix, Rashmi Priya Furosemide Lasix. Yes, loop diuretics. So, almost everybody is correct. We give furosemide. So, drug of choice is furosemide. So, my another question is, you give furosemide, you have taken out the fluid out of the body, still patient is not improving. Now, what is the fluid of choice? What is the fluid of choice? After giving furosemide, patient is not improving. It means the patient hyponatremia is not fully corrected. Tell me what is the fluid of choice. I am waiting. Madhuri was correct, Ravinder, Rajvish, Shefali, everybody was correct. Now tell me the fluid of choice. 3% sodium chloride, Nimijet, very good. So this is hypertonic saline, you are absolutely correct. Dr. Tilak is also correct, hypertonic saline. So here it is water intoxication. So this is TUR syndrome, also known as dilutional hyponatremia, also known as water intoxication. What are the risk factors? We discussed surgery duration more than 90 minutes, or if the size of gland is more than 75 grams. What is the drug of choice? Diuretics, that is furosemide, and what is the fluid of choice? That is hypertonic saline. So, Rajesh, Mohan Singh, Satish Kumar, Dr. Ajay Kumar, Dr. Richapal, Galva, Rashmi Priya, everybody was correct. Now, see the question number 3. See, some of students are having the fear of longer questions or bigger questions. Don't have any kind of fear of longer or bigger questions. Bigger question means more information is there, right? So, the probability of marking a correct answer is more if the question is a bit big. See the question number 3. See the age, 78 years old man without medication, coexisting diseases, underwent TURP for BPH under spinal anesthesia, 2.5 ml of hyperbaric bupivacaine 0.5% that extended to T10 level as tested by pinprick. Heart rate at the start of operation was 85 beats per minute. BP was 140/80, ECG was normal, SpO2 98%. Patient was positioned in lithotomy posture and surgery was done successfully. What is the most common complication that you can expect from the procedure done in this patient? So, first you tell me which procedure is being done. Yes, it is mentioned TURP. And you tell me, in transurethral resection of prostate, what is the most common complication? I am waiting for your answer. I am waiting for your answer. Yes, Almost everybody is correct. Vikram, Rupak, Pooja Payal, Shweta, Aditya, Shweta Jaiswal, Ankur, Ankul Yadav, Kiran Arora, Anuj Tiwari, Aditya, Shweta again, Arvind Semalia, yes, Ritik Sharma, Sonu, Sachin, everybody is correct. What? The most common complication of TURP is retrograde ejaculation, and it is seen in how many cases? 75% cases, right? So, see what are the complications of TURP? TURP, you know, it's a gold standard for benign prostatic hyperplasia, and the most common complication is retrograde ejaculation. Other complications are impotence, seen in 10% of the cases, and incontinence, seen in less than 1% of cases. Clear? So, correct answer for the question is B, retrograde ejaculation. Now, see next question. Question number 4. 45 years old housewife presented to emergency department with complaints of excessive drowsiness, decreased oral intake for past 3 days. In the last 3 years, she had difficulty getting up from squatting position, combing her hair, dressing, complained of increased sensitivity to cold. There is cold sensitivity, skin dryness, increased hair loss, easy fatigability. On physical examination, periorbital puffiness, dry and coarse skin was noted. No tremors or fasciculations. What is your diagnosis? Very, very easy question. You can see all these are the manifestations of, yes, everybody is correct. Vikram, Stella, Yogesh, Anuj, Nikhil, Partha, Ankul Yadav, Rahul Kumar, Navjot, Simran Yadav, Deepti Bhattu, Prabhas, Fluffy, Adrenaline, Aditya Raj, everybody is correct that this patient is having signs and symptoms of hypothyroidism. So, my next question to you all, you tell me, what is the most common cause of hypothyroidism worldwide? Tell me. For this, the correct answer is A, that is hypothyroidism. What is the most common cause of hypothyroidism worldwide? Hypothyroidism worldwide, most common cause. You know the answer? Tell me. I am waiting for your reply. Dr. Imran Ortho. Most common cause of hypothyroidism worldwide. Hashimoto's, yes. Shushruta, Aditya Raj, Yogesh Verma, Deblina, everybody is correct. It is Hashimoto's thyroiditis, and you know the most common cause of hyperthyroidism worldwide, that is Graves' disease. Simple. So, see the signs and symptoms of hypothyroidism. There is fatigue, increased cold sensitivity, there is constipation, dry skin, weight gain, there is puffy face, generally there is fluid collection in the body. So, patients are having pericardial effusion also, there is hoarseness of voice, there is muscle weakness, muscle ache, fatigue, menorrhagia, there is thinning of hair, loss of outer 2/3 of eyebrow. These patients have goiter also, there is bradycardia, and the question you have to remember, bradycardia, but these patients have diastolic hypertension. So, this is a common mistake you do in the exam. Patients of hypothyroidism are suffering from hypertension, not the hypotension. Clear? Now, see the question number 5. A 75 years old North Indian woman presented to OPD with complaints of fever. This lady is having fever. Since 1 month, there is generalized weakness, anterior neck swelling since 4 years, there is swelling in the neck, rapidly progressing since past 3 to 4 months, pain over the swelling and hoarseness of voice. Can you see here? There is pain over the swelling, there is hoarseness of voice. Why in thyroid swelling there is hoarseness of voice? Because there is invasion of which nerve? Recurrent laryngeal nerve. Okay. Patient further reported history of weight loss and decreased appetite. She denied dysphagia, dyspnea, any cancer history in the family. So what are the catch points? Age of patient 75 years. Patient is having rapidly progressive thyroid swelling. And can you see there is pain over the swelling and there is involvement of recurrent laryngeal nerve because there is hoarseness of voice. Tell me what is the correct answer. Yes, Sonia, Mohan, Anaplastic, Aarti Yadav, Stella, Sushruta, Bombay Blood, Serotonin, Ritvika, Tanisha, Irshad, Priyanka, Wasim, Nikhil Bhardwaj, Arvind Semalia, Mohan Singh, Priyanka Parmar, PG aspirant Yogender Huda. Everybody is correct. What is the correct answer? Anaplastic carcinoma. See, by looking at the age of patient, you can also crack the question. So, how you can crack the question? Papillary carcinoma thyroid is seen in young females, generally ages 25 to 40. Follicular carcinoma, it is seen in 5th to 6th decade, that is 50 to 60. Medullary is also seen in 50 to 60 years of age. Anaplastic, it is seen in 7th to 8th decade. 7th to 8th decade. Okay. See, follicular carcinoma is seen in iodine deficient areas, the areas where there is iodine deficiency. So, these patients have goiter, and if a patient is having goiter, patient comes to you telling that, sir, I am having sudden increase in the size of swelling. But in follicular carcinoma, there is minimal pain over the swelling, there is no invasion of recurrent laryngeal nerve, trachea or esophagus, so there is no dyspnea, dysphagia or hoarseness of voice. Clear? And age is 50 to 60. So, here what is the correct answer? This is D, that is anaplastic. Right? So, you have to remember the age also. Young females, papillary carcinoma, age 50 to 60, follicular. In medullary carcinoma, there is positive family history of what? Since it is associated with men 2A, 2B, there is positive family history of pheochromocytoma or hyperparathyroidism. Pheochromocytoma or hyperparathyroidism. And what is the clue about anaplastic carcinoma? Age 70 to 80, severe pain over the swelling, sudden increase in the size of swelling, there is direct invasion, so involvement of trachea, esophagus, recurrent laryngeal nerve, and because of these there is dyspnea, dysphagia and hoarseness of voice. Simple. Now, see the question number 6 and tell me what's the correct answer. A 19 years old female, see the age, 19 years old female presented with progressively increasing midline swelling for 2 months. She is having increasing swelling, progressively increasing swelling. Neck examination revealed 3 into 2 into 2 centimeter swelling on the right side of neck extending from midline to anterior border of sternocleidomastoid. It's firm, mobile, there is enlarged lymph node involving level 2, level 3, each measuring 1 into 1 centimeter. See the clue, serum calcitonin was raised 100 times above the normal. All of the following given statements regarding the diagnosis of above case are true except. So, patient is having swelling in the neck, involvement of lymph nodes, clear. So, there is lymph node involvement simultaneously. There is increased calcitonin, there is raised calcitonin. Can you guess what is this tumor? This is medullary carcinoma, Saptarshi. Very good, it's medullary carcinoma, and you know that medullary carcinoma arises from parafollicular C cells. Both hematogenous and lymphatic spread are seen in medullary carcinoma. It is TSH independent tumor. Very important point. This is TSH independent tumor, means it will not take radioactive iodine, and that's why radioactive iodine is useless in this case. 80% cases are sporadic and 20% cases these are associated with MEN 2A, 2B. Okay, so let's see what was the answer. Madhuri is correct, Shushruta correct, Stella is correct, Mohan Singh very good, Shefali Shankar, Dr. Tilak, Irshad Ahmad, Partha, Kiran Verma, everybody is correct. Very good. What is the correct answer? It is TSH independent. So C, this is not dependent on TSH. Clear? So see, this medullary carcinoma thyroid, it arises from parafollicular C cells, and you know this parafollicular C cells are derived from ultimobranchial bodies. It is going to secrete calcitonin, that's why there is raised calcitonin, and you have to remember, despite of raised calcitonin, the serum calcium is normal. Despite of raised calcitonin, serum calcium is normal. Okay. So in the exam, what kind of clues you will get in the question? That calcitonin is raised, CEA is raised. If you are going to perform FNAC, there is presence of amyloid stroma. Patient will give history of diarrhea, and there is positive family history. What kind of history? There is family history of pheochromocytoma or hyperparathyroidism, and you know both hematogenous as well as lymphatic spread is seen in medullary carcinoma diagnosed by FNAC. Since it is TSH independent tumor, this is TSH independent tumor, and that's why radioactive iodine ablation cannot be used. This is not used. That's why we go for extensive surgery. What kind of surgery? We perform total thyroidectomy plus routine central lymph node dissection plus ipsilateral MRND if the size of tumor is more than 1 centimeter, and any lymph node is positive, we go for bilateral MRND. You tell me what is the full form of MRND? Modified radical neck dissection. Simple. So what you have to remember, that it is associated with raised calcitonin. Despite of that, the calcium level is normal, and the clue that there is history of diarrhea, presence of amyloid stroma, tumor is TSH independent, so radioactive iodine ablation is useless. Now question number 7. Just by looking at the image, I think you can solve this question. You are a junior resident in surgical department, and during your morning post-op rounds, you see the following finding in the image of a patient who underwent total thyroidectomy. Can you see this kind of problem? Right? The patient was operated for medullary carcinoma thyroid. What was done? Total thyroidectomy 3 days before. Tell me, what is the probable cause? Let me check. Yes, Sushruta, very good. Dr. Vikram, Stella, Sachin, Fool Kumar, Serotonin, Yogesh Verma, Keshav, Manjunath, Ram Vivek, Adrenaline, Saptarshi Das, Vandana Rai, Satish Kumar, Mohan Singh, Dr. Rahul, Shweta Jaiswal. Yes, everybody is correct. What? There is parathyroid insufficiency. Why? Because the patient is having carpopedal spasm. And what is the cause of this carpopedal spasm? Yes, this is hypocalcemia. And what is the cause of hypocalcemia? There is vascular infarction. Whenever we are ligating inferior thyroid artery away from thyroid, there is vascular infarction. And generally on which day this parathyroid insufficiency is seen? This question is asked. It is seen on 2nd to 5th day of surgery. What will be the manifestation? Patient can have carpopedal spasm, there is tingling, there is numbness. Sometimes they ask you how to manage. So if there is mild to moderate symptom, calcium level more than 8 gram %, we give oral calcium supplementation. Severe symptoms or the calcium level is less than 8 gram %, we give IV calcium gluconate. Yes. So Sujit, Trozyucine, very good. Hypocalcemic tetany, Manjunath, carpopedal spasm, Mohan Singh. Yes, everybody is correct. So correct answer was B. The patient was having carpopedal spasm because of parathyroid insufficiency. Okay. Read this question. 22 years old male college student came to casualty with complaint of swelling in the right side of neck region. He has googled his symptoms and claimed he has anaplastic carcinoma thyroid. On physical examination, there is small solitary thyroid nodule. On FNAC, it is follicular adenoma, follicular neoplasm. What is the best surgery? Tell me. Tell me, what is the best surgery? The patient is having follicular adenoma on FNAC. You know that FNAC cannot differentiate follicular adenoma from follicular carcinoma. So let's see. Here, some people, I mean, Sweta is saying that it is B, Bhagyashree is saying that it is C, Sultan Ali is saying that it is A, but most of the students are saying that it is C. Now see how we are going to manage. This is follicular adenoma, okay. So what you do, you perform hemithyroidectomy. Since in the right lobe of thyroid gland, this is the thyroid, in the right lobe of thyroid gland, the lesion is there, so you perform hemithyroidectomy. When you perform hemithyroidectomy, you send this specimen to the pathology department, you get the report, and in the report, if there is no capsular invasion, there is no vascular invasion, it means there is no follicular carcinoma. So no need to go further. If there is vascular invasion, if there is capsular invasion, in these cases you have to go for completion thyroidectomy. So what is the correct answer? First we will go for right hemithyroidectomy. After that, if the report says that there is capsular invasion, there is vascular invasion, in these cases we go for completion thyroidectomy. Yes. So here most of you were correct, but everybody was not correct. So let us discuss how we manage. First thing, that FNAC cannot differentiate follicular adenoma from follicular carcinoma. Clear? So that's why on FNAC, if you get the report, it is mentioned that it is follicular neoplasm. So we take this patient and perform hemithyroidectomy. That specimen is sent to pathology department, you get the report, and if report says that there is vascular invasion, there is capsular invasion in biopsy, in that case we go for completion thyroidectomy. Simple. So in general, how you are going to make the diagnosis of follicular carcinoma? Biopsy. And what is the treatment of choice? Total thyroidectomy. Only there is hematogenous spread. Most common site of metastasis is bone. Which bone? Thoracic vertebra. Which bone? It is thoracic vertebra. Clear? Since there is only hematogenous spread, there is no lymphatic spread, that's why total thyroidectomy is sufficient. And you know what kind of secondaries are seen? There is pulsatile secondaries. And what are the pulsatile secondaries? These are osteolytic and hypervascular. These are osteolytic and hypervascular secondaries known as pulsatile secondaries. You people tell me, there is another malignancy in which pulsatile secondaries are seen. Tell me. There is another malignancy in which pulsatile secondaries are seen. I am waiting for your reply. I am waiting for your reply. Pulsatile secondaries are seen. Prashant Srivastav is asking that. Okay, Prashant. Nice question. RCC, very good. Shivam, Shriyam, Amresh, Irshad, yes, Mohan Singh, Shushruta, everybody is correct. Pulsatile secondaries are also seen in RCC. Simple. Now see the question number 9. Easy question, you tell me what's the correct answer. 50 years old male presented to you with thyroid nodule of 5 centimeter. Thyroid nodule 5 centimeter in size, mobile, it's mobile but causing compressive symptoms. All are true except. I am waiting for the answer. Tell me what is the correct answer. Read the question and what is the correct answer. Vikram is saying that A. No, FNAC is investigation of choice. All except. All except. So which option is incorrect? Ramiz Alam is correct. Vandana Roy is correct. Dr. Avna is correct. See, it's a thyroid nodule, and for thyroid nodule FNAC is investigation of choice. There are 3 limitations of FNAC. 1. Follicular adenoma, follicular carcinoma, you cannot differentiate. Riedl's thyroiditis, there is fibrosis, so FNAC cannot diagnose. And third is thyroid lymphoma. This is correct. FNAC cannot distinguish follicular adenoma from follicular carcinoma. That is correct. Managed by total thyroidectomy, yes, it can be managed by total thyroidectomy if it's malignant and there is compressive symptoms. See the last option, cold nodular diagnostic of malignancy. No, cold nodules are not diagnostic of malignancy. First you tell me in what percentage of cold nodules there is malignancy. Only in 17 to 20%. So only in 17 to 20% patients of cold nodule there is malignancy, right? So it is not diagnostic of malignancy. So what is the correct answer for this question? It is D. Rest 3 options are correct. Clear? So generally investigation of see there are 2 questions. Suppose there is thyroid nodule. What is the first investigation done? The first investigation done is thyroid function test, and the investigation of choice it is FNAC. Now if there is cold nodule, how much is the risk of malignancy? In the cold nodule, risk of malignancy is 17 to 20%, and how much is the risk of malignancy in hot nodule? 1 to 3%. Got it? So cold nodule is not diagnostic of malignancy. That was incorrect option. Yes, Anuj, Stella, Shefali, Prabhas, Dr. Richa Pal Galwa, Shweta Jaiswal, Mohan Singh, Stella, all of you are correct. Now next question, you tell me, somebody was asking that, sir, what is the relation of nerves, which nerves are injured? Tell me. So this is question related to nerve injury. Have a look. 50 years old female, teacher by occupation, presented with complaints of swelling in front of neck, which moves with deglutition, means thyroid swelling. Examination revealed multinodular goiter with low TSH, means patient is having hyperthyroidism, so there is toxic nodular goiter. After achieving euthyroid state, the patient was taken up for total thyroidectomy. Most common nerve injured during thyroidectomy, you tell me the answer. What is the most commonly injured nerve during thyroidectomy? I am waiting for your reply. Yogi, Arvind, Sushruta, Rosie, Debalina, Prakash, Stella, they say A. Ayushman is saying B. Partha is saying B. So most of you are confused between A and B. See, it's very easy. Let me tell you this simple concept. This is the thyroid gland. Okay, you know the superior thyroid vessels. Superior thyroid vessels are ligated close to thyroid. Why? To prevent the injury of external branch of superior laryngeal nerve, that is also known as external laryngeal nerve. I am repeating. superior thyroid vessels are ligated close to thyroid to prevent the injury of external branch of superior laryngeal nerve, that is also known as external laryngeal nerve, and inferior thyroid artery is also ligated close to thyroid. Why? To prevent the vascular infarction of parathyroid gland. Simple. So, in thyroidectomy, the most commonly injured nerve is not recurrent laryngeal nerve, it is external branch of superior laryngeal nerve, that is also known as external laryngeal nerve. So, most commonly injured nerve is what? External laryngeal nerve, also known as external branch of superior laryngeal nerve. Clear? So, what is the correct answer? Correct answer for this question is A. So, you have to remember, because most of the students are confused in this question. Some of you are having this kind of thought that the most commonly injured nerve in total thyroidectomy or in thyroidectomy is recurrent laryngeal nerve. No, it is not. It is external branch of superior laryngeal nerve. Now, read the question number 11. First, see the image. If you see the image, you can have rough idea. See the image. The patient is having some kind of inflammatory lesion. So, a 4 years old girl presented with left sided anterior neck swelling, about a week duration. It is painful, progressively increased in size. There was dysphagia. Fever was absent at presentation, but on the second day there was fever. So, fever was there on second day. History of being treated for upper respiratory tract infection. So, there was history of upper respiratory tract infection. No hoarseness, no difficulty in breathing, are features suggestive of hypo or hyperthyroidism, means patient is euthyroid. All of the following statements are correct about the given condition except, can you see? Young female, age 4 years, means a female child, there is pain, there is fever, there is history of upper respiratory tract infection. So, what is the diagnosis? You tell me first. What is the diagnosis? You tell me first. There is fever also. Shweta Sharma is saying Riedel's thyroiditis. No, it is not Riedel's thyroiditis, Shweta. It is something else. It is thyroiditis. Which type of thyroiditis? Which is having fever? It means there is pus collection. Tell me. If there is pus collection, we use the term suppurative. Now, 2 clues I have given. Tell me what is the name of this condition. 2 clues I have given. There is suppurative thyroiditis. So, what is the name? It is acute suppurative thyroiditis. There is pus collection. Let me tell you, whenever there is fever, there is upper respiratory tract infection. From upper respiratory tract infection, actually, these patients are having persistent pyriform sinus. And because of this persistent pyriform sinus, the bacteria reaches thyroid. Which bacteria? Staph aureus. If there is pus collection in relation to thyroid, obviously what we have to go for? Incision and drainage, and we have to give antibiotics. Clear? Why it is common in children? Because children are having this kind of congenital abnormality, that is persistent pyriform sinus. Okay. So, look the options first. More common in children, that is correct. Most common causes, presence of pyriform sinus, correct. Most common organism is Staph aureus, since this is pus collection. There is pus collection. So, what we have to give or go for IND, and we give antibiotics. Clear? So, it is incision and drainage, and we give antibiotics. So, D option is incorrect. D option, it is incorrect. Since some of you were not very clear about this condition, so let us discuss in detail. Acute suppurative thyroiditis. Suppurative means there is collection of pus, and if there will be pus collection, obviously there will be fever. Sometimes there are chills and rigor. There is leukocytosis, raised ESR. So this is suppurative infection. Most common organism is Staph aureus. Why it is more common in children? Because there is persistent pyriform sinus, and this pyriform sinus is a connection between oropharynx and thyroid. So that's why there will be history of either otitis media or upper respiratory tract infection. After that, patient develops this condition. Okay, so fever is there, chills is there is severe neck pain radiating to jaw or ear, and since it is abscess, we go for IND and we give antibiotics. Simple. So this was acute suppurative thyroiditis. Read the question number 12. 45 years old female presented to OPD with history of weight gain, decreased appetite, lethargy, weakness. All these are signs and symptoms of what? Hypothyroidism. Now see the clue. Anti-TPO was positive. Tell me what's the diagnosis. First, tell me what is the diagnosis. It's very easy question. This question was asked many times in the exam. I'm waiting for your answers. Very good, Nikhil. Hashimoto's, Saptarshi Hashimoto's, Vikram Hashimoto's. Okay. So it's Hashimoto's thyroiditis because there is anti-TPO. Hashimoto's thyroiditis. Simple. What is the other name of Hashimoto's thyroiditis? It is also known as struma lymphomatosa. See the name? It is also known as struma lymphomatosa. So can you find out the one malignancy hidden in the term struma lymphomatosa? Which malignancy is hidden? Tell me. Struma lymphomatosa. So there is increased risk of lymphoma. Not only lymphoma, there is increased risk of papillary carcinoma thyroid also. Simple. So what happens in Hashimoto's thyroiditis? There is CD4 mediated CD8 cytotoxicity. Because of that, there is permanent destruction of thyroid follicle. And if there is permanent destruction of thyroid follicles, what's the problem? Patient is having are going to develop permanent hypothyroidism. And if patient develops permanent hypothyroidism, we have to give levothyroxine lifelong. Sometimes there is suspicion of malignancy, and which malignancy? Either there is lymphoma or papillary carcinoma thyroid. So let's see. Megha Patil, Yogesh Verma, Dr. Nadeem Ali Khan, they were correct. So correct answer is what? Both papillary carcinoma and lymphoma. So it is D. Both A and C are correct. There is another question which is asked in pathology. You know, Hashimoto's thyroiditis is autoimmune disorder. And what is the autoantibody? That is anti-TPO, right? Which kind of cells are there? Hurdle cells or Ashkenazi cells, right? This is seen on FNAC, and since it leads to permanent hypothyroidism, so what is the treatment? We give lifelong levothyroxine. We give lifelong levothyroxine. Question number 13. This question is asked almost every year. Just by looking at the image, tell me what is the correct answer. I am waiting for your reply. See the nucleus. If you see the nucleus is having this kind of appearance, but in this malignancy, this kind of nucleus is there. Yes. Simran Yadav, Mohan Singh, Umesh Nandan, Stella, Amresh Singh, Nikhil Bhardwaj, Shefali, Siddhi Chavan, Shushruta, Debalina Patra, Ankit Shah, Megha Patil, G Madhuri, Mudassir Nazar, Saurav Mishra. Everybody is correct because this question is asked almost every year in each and every exam. This is papillary carcinoma, and you tell me what is the name of this appearance. This is optically clear nuclei. Optically clear nuclei. That's also known as orphan NEI nuclei. Orphan NEI nuclei. Simple. So what is the correct answer? Easy question, frequently asked question. It is papillary carcinoma. Okay. So in papillary carcinoma, you are going to find optically clear nuclei, that's also known as orphan NEI nuclei. Read this question and then tell me what is the correct answer. First, see the age. 65 years old women with lump size 5 into 4 centimeter in the right breast upper quadrant. FNAC, there is invasive ductal carcinoma. Which mastectomy was done? Pritesh mastectomy. Which of the following structure is preserved during the procedure? I am waiting for your answer. Which structure is preserved? Tell me. I am waiting for your answer, everybody. For the previous one, everybody was correct, papillary carcinoma. Now for this question, I am waiting for your answer. It is intercostal brachial nerve, pectoralis major, pectoralis minor, axillary fascia. Yes, Saptarshi is very good, Saptarshi. Yogesh Verma, you are correct. Siddhi Chavan is you are also correct. Saptarshi Das correct. Umesh Nandan is also correct. Sushruta, Kobbanola, Suresh is also correct. See, let us discuss a bit because it's easy to understand. This is the breast, this is the nipple, this is the areola, and this is the lump. What kind of incision is given during mastectomy? We give elliptical incision. And in this elliptical incision, what is removed? Can you see? These structures are removed. So we are going to remove nipple, areola, skin, breast tissue, breast mass. That is simple mastectomy. With simple mastectomy, if you remove level 1 lymph node, that is extended mastectomy. With simple mastectomy, if you remove level 1, level 2 lymph node, it is modified radical mastectomy. And with this, if you remove level 1, level 2, level 3 lymph node plus excision of pectoralis major and pectoralis minor, that is radical mastectomy, also known as Halsted radical mastectomy. So I am repeating. In modified radical mastectomy, apart from simple mastectomy, you remove level 1, level 2 lymph node. In Halsted radical mastectomy, you remove level 1, 2, 3 lymph node, pectoralis major and minor. There are certain modifications of MRM, modified radical mastectomy. What's the modification? First, Pritesh modification. Pritesh wanted to remove level 3 lymph node, so he excised pectoralis minor. And there is Canalon's modification. He wanted to remove level 3 lymph node, so he divided pectoralis minor, removed level 3 and resuture it. So I am repeating. In Pritesh modification, apart from simple mastectomy, there is removal of level 3 lymph node. So 1, 2, 3 lymph node with excision of pectoralis minor. And in Scanlon's modification, there is division, not the excision of pectoralis minor. But pectoralis major, it is not removed in modified radical mastectomy, it is removed in radical mastectomy. So what is the correct answer here? The correct answer is pectoralis major. So Jailendra, Gaur, Prashant, Srivastav, Anuj Tiwari, Dr. Ayush, Aishwarya Saha, Prashant Avasthi, everybody is correct. Correct answer is pectoralis major. Okay. So see the modifications of MRM. There is Auchincloss modification. It is same as MRM. There is Pritesh modification, in which we go for excision of pectoralis minor. Scanlon's modification, in which we go for division, not the excision of pectoralis minor. Question number 15, just by looking at the image, tell me the answer. What is the name of this condition? So see the question. Known case of papillary carcinoma of left breast. There is breast cancer. Came to your hospital for surgery. Modified radical mastectomy was done. So MRM was done. And on second post-operative day, during your rounds, patient presented with following findings as shown in the figure below. Which nerve would have been damaged during the operative procedure? Tell me, which nerve has been damaged here? Yes, I'm waiting for your reply. Ramiz, Dr. Tilak, Mudassir Nazar, Yashwant, Sunny, Ashish Ranjan, Rupak, everybody is correct, everybody. Prakash, Mahadev, Arka Chatterjee, this is winging of scapula, and you know that this winging of scapula is because of injury of which particular nerve? Yes, long thoracic nerve. It is also known as Bell's nerve. Tell me, this nerve supplies which muscle? Serratus anterior. Yes, so because of that, what happens? There is winging of scapula. So what is the correct answer for this question? It is B. You tell me, thoracodorsal nerve supplies which muscle? So thoracodorsal supplies the latissimus dorsi. There is intercostal brachial nerve. So generally this intercostal brachial nerve, it supplies the sensation of under surface of upper arm and the skin of chest wall along posterior axilla. So whenever this nerve is injured, what happens? There is cutaneous anesthesia. And this intercostal brachial nerve is generally injured during sentinel lymph node biopsy. This is most commonly injured nerve during sentinel lymph node biopsy. And we discussed long thoracic nerve supplies serratus anterior. What is the function of serratus anterior? It fixes scapula to the chest wall during abduction of shoulder and extension of arm. That's why division of this nerve leads to winging of scapula. Right? Question number 16. You tell me, it's easy question. Similar questions were asked many times in exam. 55 years old female presented with complaints of lump in right breast for 6 months, which progressively increased in size to reach present size. Physical examination revealed a mobile lump of size 4 into 3 centimeter in right breast upper quadrant. On raising both of the hand, dimpling of skin. So what? There is dimpling of skin. Dimpling in carcinoma is due to, I'm waiting for your reply, tell me what is the correct answer. Ayush, Jalendra Gond, Ayush, Arnab Roy. Correct. Shefali Shankar, Ritvika Saha, Hema Sahu, Simran Yadav, Amruta Charu, Joshi, Deblina Patra, everybody is correct. So what? It is because of contraction of ligament of Cooper. So because of contraction of Cooper's ligament. So that is dimpling. Okay. Some of you are confused that what is dimpling, what is puckering, and what is cancer in cuirass. See the picture. If you see this picture, I'm sure you have seen the dimples. Yes. So if you have seen the dimples, dimples means depression. So here you can see there is skin depression, that is dimpling, and puckering means there is wrinkling of the skin. Here you can see there is skin wrinkling. So dimpling and puckering, in both of these there is involvement of ligament of Cooper. Dimpling is skin depression and puckering is wrinkles in the skin. What is cancer in cuirass? Here you can see there are presence of multiple nodules and ulceration. There is involvement of breast skin and chest wall. So that is cancer in cuirass. So 2 questions. First, In dimpling and in puckering, in both there is involvement of which ligament? There is involvement of ligament of Cooper. In dimpling there is skin depression. In puckering there is wrinkles or skin fold. You know that if there is cutaneous edema and the appearance is like orange peel, that's known as peau d'orange. And what is the cause of peau d'orange? The tumor cells are going to enter into lymphatics. So that's the cutaneous edema. And what is cancer in cuirass? There is presence of multiple nodules, ulceration in the breast skin, and there is involvement of chest wall. So these are the 4 questions which are asked: dimpling, puckering, cancer in cuirass, and peau d'orange. Clear? So everybody was okay. Prashant, you want to see the live example? So see, you can see the dimples here. So this is depression. Okay, so easy to remember. And if you have seen tissue paper or skin wrinkles, clear, that is known as what? Puckering. This question was asked, or similar question was asked in AIIMS long back. I am waiting for your reply. Which of the following statement regarding Oncotype Dx or diagnostic test is true? I am waiting for your reply. First option, hormone receptor negative cancer. 21, Oncotype gene assay. Predict the use add-on hormonal therapy for lymph node positive cancers. Yogi, Tanisha, Prajakta, Amresh, Amruta, Sujit, Devalina, Mahadev, Shashi Kiran, Navjot, almost everybody is correct. Now what is multi-gene test? It's very easy to understand the concept. Have a look. Multi-gene test. So the term is self-explanatory. If there is a young female having breast cancer, newly diagnosed case of breast cancer, in that I am going to do the biopsy. On the biopsy specimen, I am going to see the expression of multiple genes. So you see the expression of multiple genes. On the basis of expression of multiple genes, you are going to predict what? The responsiveness to chemotherapy, the recurrence rate, or the survival. Responsiveness, whether the tumor will respond to chemotherapy or not, how much will be the risk of recurrence, and survival, that is multi-gene test. One of the multi-gene test is Oncotype Dx. So how many genes are assessed in Oncotype Dx? 21. There is PAM 50. So how many genes are assessed? 50. And MAMA print, we are going to assess 70 genes, right? So we predict responsiveness to chemotherapy, likelihood of survival, and recurrence rate. Coming to Oncotype Dx, in which patients we are going to predict the responsiveness to chemotherapy? These patients are lymph node negative, hormone receptor positive, HER2 new negative. How to remember? The patient is having good prognostic factors. So lymph node negative is a good prognostic factor. Hormone receptor positive or ER/PR positive, good prognostic factor, and HER2 new negative, good prognostic factor. So if you see the question again, hormone receptor positive, so this is incorrect. 21, Oncotype gene assay, correct. Use add-on, not hormonal therapy, chemotherapy. So this is also incorrect for lymph node negative cancers. So what is the correct answer for this question? It is B. It is B, and most of you were correct. Most of you were correct. So here the correct answer for this question is B. Okay. Coming to question number 18, you tell me the answer. Which of the following statement are true about RCC? First, renal masses appear as tumor deformities distorting the renal outline, obviously, or collecting system on IVP. Most common mode of spread is lymphatic in RCC. Robson staging and Fuhrman grading are used in RCC. RCC can present with anemia, hypertension and erythrocytosis, and the most common presentation of RCC is abdominal mass. Tell me which is correct. See the options. Hema Sahu A. Yes, I am waiting for your reply. Everybody, waiting for your reply for this question. Okay, let's discuss one by one. First, you tell me option A, first A is correct or incorrect? It's correct. So, if there is renal mass, obviously it appears as a tumor deformity distorting the renal outline. So, this option is correct. Option A, it's correct. What is the most common route of spread in RCC? It is not lymphatic, it is hematogenous. This is hematogenous. Clear? Robson staging and Fuhrman grading are used in RCC. This is correct. RCC can present with anemia, hypertension and erythrocytosis. You know that kidney is going to produce erythropoietin. So, when a functional mass replaces the tumor, there is anemia. If it is going to produce renin, there is hypertension, and if it is going to produce erythropoietin, because of that there is erythrocytosis. So, this is correct. What is the most common presentation of RCC? That is hematuria. It is not the abdominal mass, it is hematuria. So, A, C and D, these are correct. So, correct answer for this question is 1. Okay. So, Hema Sahu, free Netflix, you were correct for this question. So, this is RCC. Okay. So, important point, what kind of spread is there in RCC? Hematogenous. And what is the most common presentation? Hematuria. Okay. If we see the renal masses, what happens? Whenever there are renal masses, suppose it is RCC or benign cyst also, it appears as tumor deformity distorting the renal outline or the collecting system on IVP. There are named grading or named stagings which are asked. Robson staging, Fuhrman grading, these are seen in RCC. Jackson staging in carcinoma penis and Gleason grading in carcinoma prostate. Gleason grading, carcinoma prostate. Simple. Carcinoma prostate. Simple. Okay. So, these are the named stagings, these are the named stagings which are asked in exam. Okay. Now, question number 19. A 44-year-old female was admitted to the hospital with 6 months history of progressive bloating sensation in abdomen. The patient has a family history of tuberous sclerosis. So, can you see this patient is having tuberous sclerosis. Family history on his maternal side. On palpation, a mass. On palpation, the mass was identified in left lateral abdominal area. So, in the left lateral abdominal area, what there is mass, patient underwent an ultrasound and hyperechoic mass size 10 centimeter was identified in left abdominal area, means left kidney. So see, what are the pointers? The patient is having tuberous sclerosis. One thing you noticed. Second thing you noticed that patient is having mass in left kidney. CT examination reveals a mass with mixed density, size 8 into 10 into 12 centimeter. So lesion was arising from left kidney displacing kidney to right. Biopsy was done, sent for immunohistochemistry, and this is positive for HMB45. Tell me which tumor is this? On the basis of these three findings, tell me which tumor is this? Dr. Tilak, AJ, Arvind Samalia, Robinson, Mahadev. Yes, almost all of you are correct. So this is a case of angiomyolipoma. You know that angiomyolipoma, it is associated with tuberous sclerosis, and on immunohistochemistry it is positive for HMB45. There is another feature that this patient is having macroaneurysm. Right? How you are going to differentiate angiomyolipoma from RCC? In RCC there is calcification. In angiomyolipoma there is presence of what? Lipoma means fat. So presence of fat, absence of calcification differentiates it from RCC. So what is the correct answer for this question? Correct answer for this question is C, that is angiomyolipoma. Clear? Dr. Rahul, very good, mixed density tumor, so angiolipoma. Okay. Next question. So let's discuss about angiomyolipoma. This is very, very important, and many times this question was asked. This is benign tumor, and if you break it, this is angio plus myo plus lipoma. So there is matured blood vessel, muscle and fat. It is associated with tuberous sclerosis. This is associated with tuberous sclerosis. Clear? And we discussed that on immunohistochemistry, there is HMB45 which is positive, there is presence of macroaneurysm, and what is the characteristic feature? There is presence of fat and absence of calcification, which is going to differentiate it from RCC. Right? Now see the question number 20, easy question, I am waiting for your reply. Tell me what is the correct answer. 60 years old male during his routine health checkup was found to have mass in right kidney, which was later found to have RCC. Which of the following is not the component of too late triad? So which of the following is not the component of too late triad? Tell me. Very good. Almost everybody is correct. Ritvika Saha, Dr. AJ, Shefali Shankar, Madhuri, Arvind, Sunny, Shweta Jaiswal, Ankul Yadav, Krish, almost everybody is correct. So what is the component of two late triad? Obviously, there is mass, there is pain, there is hematuria. There is mass, there is pain, there is hematuria, and all of you know that what is the most common symptom? The most common symptom is hematuria. Suppose I am asking you Wilms tumor. In Wilms tumor, what is the triad? So there is mass, there is hematuria, at the place of pain there is fever. At the place of pain there is fever. Clear? So what is the correct answer for this question? It is D, pyrexia. So it is too late triad. Why it is called too late triad? Because mass pain and hematuria, it is seen only in 10% patients of RCC who are having advanced disease. That's why if person is having this triad, we say that it's too late. That's why it's known as too late triad. And what is the most common presentation? And that is hematuria. Question number 21, very, very easy question. Many times this question was asked in exam. Tell me, hotspot on technetium 99 is seen in which parotid tumor? Hotspot on technetium 99. Yes, I'm waiting for your reply. Everybody is correct for fever in Wilms, Prajakta, Vandana Rai, Abhishek Gupta. Yes. I'm waiting for the correct answer. Ritvika Saha, you are correct. Yes. Till now only one person. Majority of you are marking B, right? Hotspot is seen in Wardin's tumor. And what is the other name of Wardin's tumor? Papillary cystadenoma lymphomatosum, which is also known as adenolymphoma. So everybody be careful. What is the correct answer for this question? It is A, that is adenolymphoma. What is the name? This tumor is known as Wardin's tumor. It is also known as papillary cystadenoma lymphomatosum. Papillary cystadenoma lymphomatosum. Okay, and what is the other name? This is also known as adenolymphoma. It is exclusively seen in parotid gland. Exclusively, this is benign tumor. In 10% cases, it is bilateral. It is more common in male. See, all salivary gland tumors are more common in females except Wardin's tumor. It is more common in males. And how we are going to diagnose it? By FNAC treatment is superficial parotidectomy. Most of the parotid tumors show cold spot on technetium 99, but it shows hot spot. It shows hot spot. So what is the correct answer for this question? The correct answer for this question is A, that is adenolymphoma. Okay. So why there is hot spot? Because there is high mitochondrial count. Because of high mitochondrial count in oncocytes, in oncocytoma as well as in Wardin's tumor, there are hot spots. And how we are going to treat it? By superficial parotidectomy. Simple. Okay. Now see the next question. Question number 22. One by one we are going to discuss. First you tell me which one is correct, which one is incorrect. Option number 1, epidermoid carcinoma, most common malignant tumor of salivary gland. You tell me this option is correct or incorrect. I am waiting for your reply. I am waiting for your reply. Option number 1 for question number 2. Question number 22. Yes, very good PG aspirant Trilok Chand. This is true or this is false? Shefali Shankar, false. Arvind, false. Nadeem Ali Khan, false. Ajju Chaudhary, false. So this is false. This option is incorrect. What is the most common malignant tumor of salivary gland? That is mucoepidermoid carcinoma. So mucoepidermoid carcinoma, clear? And it is mucoepidermoid carcinoma is the most common malignant tumor of salivary gland in children as well as in adults. So option 2 is correct. Now you tell me about option 3. Hemangioma is the most common neoplasm of salivary gland in children. This is correct or incorrect? I am waiting for your reply. Option number 3, it is correct or incorrect? I am waiting for your reply. Option number 3. Swati saying false. Tanisha is saying true. Vandana Rai saying false. Rituraj, let me tell you, the most common neoplasm of salivary gland in children, it is hemangioma. So this is also true. This is also true. Now coming to option number 4, you tell me adenoid cystic carcinoma. This is the most common malignant tumor of major salivary gland. Major salivary gland. Tell me, this option is correct or incorrect? Yes, option number 4 for question 22. Option is correct or incorrect? Waiting for your reply. Shweta Jaiswal is saying correct. PK Rawal saying correct. Rahul Kumar saying correct. Abhishek Gupta saying false. See, where is the catch? Here major word is there. Adenoid cystic carcinoma is the most common malignant tumor of minor salivary gland. It's minor salivary gland, not major. So this is false. And you know, pleomorphic adenoma, that is the most common neoplasm of salivary gland. That is true. So which is true? 2, 3 and 5. 2, 3 and 5. These are correct. So what is the correct answer for this question? The correct answer for this question is A. It is A. Okay. So see the important points related to salivary gland tumors, because it's very, very important. Most common neoplasm of salivary gland, that is pleomorphic adenoma. Most common neoplasm of salivary gland in children, that is hemangioma. And if it is most common malignant tumor of salivary gland, that is mucoepidermoid carcinoma in both adults and children. And for minor salivary glands, most common malignant tumor, it is adenoid cystic carcinoma. So for minor salivary gland, it is adenoid cystic carcinoma. Simple. This is very, very important. These are one-liner questions which are asked in exam. Now the question number 23, it's a one-liner question. It was asked many times, sometimes in surgery, sometimes in pathology. Tell me what is the correct answer. I am waiting for your reply. Most common site of minor salivary gland tumor. Waiting for your reply. Most common site of minor salivary gland tumor. Waiting for your reply. Yes, for previous question, most of the people were marking the correct answer. Ram Vivek Modiam, you were correct for previous one. Hemangi Purohit, you were also correct. Sonal Chaudhary, Rashmi Priya, you were also correct. Now I am asking question number 23. Tell me what is the correct answer. Majority of students are marking option A, Krish, Pavan, Shubham, A. But A is not correct. Cheek is not the most common site of minor salivary gland. Cheek is not the most common. Ray Amorin wants to ask, will NEET PG get postponed? Let's focus on this marathon first. Bhagyashri, very good Bhagyashri. Bhagyashri, you are correct. Okay, so let's discuss minor salivary gland tumor. You tell me what is the most common malignant tumor of minor salivary gland, and that is adenoid cystic carcinoma. What is the most common site? Hard palate followed by sinonasal tract. So the most common site is hard palate. This is hard palate followed by sinonasal tract. Sinonasal tract. So correct answer is B. Correct answer is B. And most of you, yes, Nimi, Nimai, Jit, you are correct. You are correct. Most of the people are marking option C, sublingual. That's not correct. That's not correct. Pragya, Vikram, Aarti Yadav, all of you are correct. Clear? So it is hard palate. So palate followed by sinonasal tract. Okay. So most common site of minor salivary gland is hard palate followed by sinonasal tract. And we discussed what is the most common malignant tumor of minor salivary gland, that is adenoid cystic carcinoma. Prabhas, Arvind, you are correct. Very good, you are correct. Okay. So it is palate. Now question number 24. A male neonate is born with an omphalocele. There is omphalocele. This entity can be distinguished from gastroschisis because in an omphalocele the protrusion is, I am waiting for your reply, tell me which one is correct. Which option is correct? Not covered by a sac, a defect in abdominal musculature, associated with intestinal atresia, associated with congenital malformations. Tell me, this is very commonly asked question. It's commonly asked question. I'm waiting for your reply. I'm not lagging in reading chat because this is live session, so that's why there is a lag in live session. Okay. I'm waiting for your reply for this question, question number 24. There is chat lag because whenever the live session is there, whatever I am going to say and whatever the reply you are giving in the chat, there is some delay. Okay, so let's discuss one by one. Omphalocele, you know, first see the image, then you are going to understand. You see these two images here, this is omphalocele, this is omphalocele, and here you can see this is gastroschisis. Okay. So in omphalocele, the bowel is covered by two layers, inner one is peritoneum and outer is amnion, right. So it is covered, but in gastroschisis there is splitting in the abdominal wall, and this splitting is on the right side of umbilicus, so bowel is exposed. Important point that in Omphalocele it is associated with congenital malformations. And what is the most common congenital malformation? Cardiovascular. Because of this congenital malformation, there is death. In gastroschisis, these patients have intestinal complications and there is intestinal atresia. There is intestinal atresia. Clear? Okay. So, let us see the question again. Now, most of you are correct. Yes. Arvind Semalia, Vijay Kumawat, Prajakta Sonawani, Prabhas, Jitendra, yes. So, majority of you are correct. Let us discuss it one by one. Since it is Omphalocele, so it is not covered by sac. No, it is covered by two layers. A defect in abdominal musculature. No, it is not a defect in abdominal musculature. Bowel fails to return to abdominal cavity associated with intestinal atresia. No, these are the features of gastroschisis. These are the features of gastroschisis. Omphalocele is associated with congenital malformations. And see, this is the image based question which is asked almost every year. Either you get an image based question related to Omphalocele, or you get an image based question related to gastroschisis almost every year. So, what are the important points? We discussed there is intact membrane or sac, outer layer is amnion and the inner layer is peritoneum. So, there are two layers, outer one is amnion, inner one is peritoneum. It is associated with trisomy 18, 13, 21. So, 13, 18, 21. And what is the most common congenital malformation? That is cardiovascular. In gastroschisis, the defect is on the right side of umbilical cord, the bowel is exposed, there is increased risk of bowel complications. There is congenital malformations are rare, but there is intestinal atresia. These are the differences. So, majority of you were correct, majority of you were correct for this question. And now see the question number 25. A 3-year-old child comes with complaint of swelling in the scrotal region. 3-year-old child, swelling in the scrotal region. On examination, swelling increases in size when the child cries. Ultrasound revealed hydrocele of hernia sac. So, first tell me what is the diagnosis. The diagnosis is mentioned here. Tell me what is the diagnosis. Question number 25, I am waiting for your reply. What is the diagnosis? And if you see the question carefully, diagnosis is already mentioned. If you look the question carefully, diagnosis is already mentioned. Tell me what is the diagnosis. Irshad, most common cause of death, congenital malformation. Yes, you are correct. You tell me what is the diagnosis of question number 25. Waiting for your reply. It is already mentioned. So, if you see the ultrasound, it says that there is hydrocele of hernia sac. It means this patient is actually having what? Hernia. And when there is hydrocele in the hernia sac, see the diagram. Here you can see this is testis and this is hernia sac. Whenever this neck of hernia sac, it is plugged by omentum or it is obstructed by adhesions, what happens? This sac is filled with fluid. So, in hernia sac, there is fluid collection because the neck of sac is plugged by omentum or it is obliterated by adhesions. So, since there is fluid collection, it is hydrocele of hernia sac. It is a type of hernia because sac is there. So what you have to do? You have to perform herniatomy. So what you have to do? You have to perform herniatomy. So see the question. The management will include herniatomy. And in which type of hydrocele we go for herniatomy? Another type, congenital hydrocele. If a patient is having congenital hydrocele, in congenital hydrocele there is patent processus vaginalis. What is the good thing? That spontaneous obliteration occurs by 2 years of age. And if by 2 years of age there is no spontaneous obliteration, in those cases we go for herniatomy. And in hydrocele of hernia sac also, what is the treatment? Herniatomy. Clear? So let's see. Majority of you were correct that it was hernia. Shweta Jaiswal is correct. Option A, herniatomy. Operated after 5 years of age? No, because it's hernia you have to operate. Shikalyani Reddy, you are also correct. Option A. Yes. Sumit Vishnoi, herniatomy, very good. SK Chaurasia, no, it's not hydrocele. It's hernia. It's hernia. Yes. Soumya Bhatt, Dr. Vibhuti Mandavaria. Mano Kharadkar, yes. Vibhuti, correct. Vinutha Reddy, Ayushman Singh, majority of you were correct. So these were the very, very important 25 questions of Surgery MCQ Marathon. We had the beautiful and intelligent interactive audience here in the live section. Thank you very much for your presence. If you want to ask any kind of query, I'm waiting for your queries in the chat box. Thank you very much for your active participation, and for most of the questions I got the correct answer by this lovely beautiful audience. Madhuri, Swati, Robin, Nasreen, Prashant. Thank you, Shweta. Thank you, everyone. Thank you very much. Okay, Vibhuti. So this is big smile for all of you for your active participation, and best of luck for your coming exams. Have this kind of enthusiasm, put your 100% in your preparation. Definitely nobody is going to stop you from getting the success. All the very best to all of you. Good luck. Bye-bye. And see, whenever we are preparing for any kind of exam, whenever we are getting up in the morning, sometimes, see what happens, we are a bit depressed in the morning, and if you are not in a mood to study, see, you have to write only 2 lines in your study table in front or on your desk. First is that today is the best day. Just read these 2 statements in your study room. Today is the best day and best time to study is now, right? These are the 2 most motivational statements, and this is also written in my studio, in my study room, that today is the best day and best time to study is now, right? So stop worrying, start studying. Nobody is going to stop you from getting success. Good luck. Bye-bye.